A very good afternoon, a very good morning, and a warm welcome, everyone who is joining us for this incredible webinar. Thank you so much to everyone who is joining, whatever part of the world that you are connecting from. We are so glad that you are joining us for this webinar. And of course, this is a regional dialogue that is focusing on us rethinking the future of maternal and child health, particularly in this environment and the landscape that has changed in terms of donation and donor funding, particularly for maternal and child health. And as we welcome people to come through, we will take you through the outline for the session. But as we are kind of allowing a little bit of time for people to join, we will get into just some highlights of a video that basically summarizes for us the reason why this particular topic is important, and particularly efforts towards advocacy to make sure that we emphasize the importance of making sure that we focus our efforts on strengthening the interventions that have been implemented for maternal and child health, especially in the Africa continent. So I'm just going to give over to the team to just take us through that video, and welcome as you are joining in. But after the video, we can then get straight into the meat of the conversation, and I'll introduce myself and the incredible speakers who are going to be speaking to us on this important subject today. Thank you.
Maternal, child, newborn health issues have already been a priority for a number of countries. Quite a number of countries, especially within the Africa region, are off track as far as reaching the targets are concerned. When we focus on Africa region, you realize that the decline is not as much as was expected or should have been. And so the trajectory or the decline that we are seeing may not get us to the SDGs. So for instance, for maternal mortality, the current mortalities, Africa contributes about 70%, just one region. For the newborn mortalities, indeed it has come down, but still we have close to 50% from Africa region. I think the exact figure is 47% from the Africa region. So one of the key advocacy issues for this year's World Health Day and the year-long campaign that is going to follow is to reprioritize maternal, newborn, and child health, and to get governments, ministries, everybody involved in the business of maternal, newborn health, because we realize that it cannot be done or it cannot be addressed just at one level. So there's a need to address it at all levels, from the government, at facility level, all the way to communities, because communities, families also have a strong role to play.
Based on the evidence that we have, countries need to accelerate action and progress in order to meet the 2030 targets for maternal health, newborn health, and child health as well. So the agenda to accelerate needs a strong advocacy strategy. So as the Africa region, we need to think through what the investment is going to be to match the ambition that we have, what the political will is going to be in order for us to meet the 2030 targets. But we also need to think about what partnerships we need to advance this agenda.
Working out an advocacy plan jointly with the different contributions of the different partners is essential in terms of bringing these plans to fruition, but also ensuring that we are also working as as one body and not working in silos.
Advocacy is really key. I think at country level, we really need to get the attentions of the leadership, senior leadership in the government, so that we can, advocate, because really our politicians need, a repetitive, kind of making sure that MNH is integrated into the policies, international policies. So, by advocating and, changing those commitments into actions can usually, progress the, MNH surfaces in different countries like Somalia.
I'll mention three things that are important. One, investment is very important. So investment in a way that that responds to the acceleration agenda that we have at the country level is critical. But secondly, is strengthening the political will so that it translates into actual investment, actual implementation of policies. That is also going to be very critical. But then the other bit is we need to think about what the evidence is telling us, and we need to become restless as a region so that we respond to what the evidence is telling us.
Women's health is such a key driver of economic development. It's a very difficult thing to unpack, but once you actually entice leadership and entice influential leaders to know that if you improve the quality of life of women, you are positively impacting on the economy of our country, then maybe the advocates will be much stronger. There is progress that we are making. We wish you can do more and much faster.
Thank you, thank you, thank you for that. Really such an excellent summary of the reason why we are having this conversation today. And once again, a very, very warm welcome to everyone who is joining us. We are just so excited that we are able to dive into session 2 on rethinking the future of maternal and child survival, particularly in the Africa continent, given the changing donor financing or aid landscape. Welcome. Do let us know what part of the world you are joining from, the organization that you are representing. Our chat line is open. We'd love to connect with you. I'm your host for this session. My name is Notem Bakula. I am the country director for the South Africa office for PATH. I also wear a second hat as the director for partnerships for the Africa region for PATH. So this is a particularly exciting conversation for me because it touches on areas of work that I am keenly interested in and which I believe are fundamental as we look not only to maternal and child health programs, but health systems in general, particularly in developing countries. Thank you so much for joining us. Thank you, Jordan from Cameroon. We see you. We see everybody who is joining. And just before we get into it, just for some basic house rules, we just want to make sure that you have muted your microphone unless, of course, you are called upon, but feel free to chat with us. And also, if there are any questions that come up in the course of the conversation, do put them in the chat box and we'll be sure to respond to them. For those of you who might not be very familiar about PATH as an organization, we are a 1,500 strong global team. We work across 70 countries globally, and 14 of those countries are in the Africa continent. And we have got a diversity of areas that we focus on, including product development, PHC, vaccines, digital health and transformation, and of course, epidemic preparedness and response. And the team that has actually facilitated this session for us today is our Center for Advocacy and Policy, our CAP team. And thank you so much to the team and for the great work that they do in terms of elevating community priorities and ensuring that we influence the local and global stakeholders around very important health issues. So that's who we are as PATH, as an organization. And once again, such a pleasure to connect with all of you, as I'm sure you're coming from different areas and different technical specialities, and we look forward to your inputs into the conversation. Now, I think it's important to kind of frame the conversation that we are having today for us to understand that, I mean, as we all know, there are so many targets that have been set by 2030, and we know we are only 6 years away from 2030. In other words, we don't have much of a window to achieve many of the targets that have been set. And it's very important for us to be sober and clear-headed about where we are, particularly with regards to maternal and child health. And as we know, the landscape has changed significantly, and we can say with confidence that we are unlikely to meet the targets that have been set for 2030. And I think that's why this conversation today is particularly important. For an example, some of the key statistics and numbers that you should be aware of is that more than 80% of countries are forecasted to miss their neonatal and maternal and child mortality targets. 80% of countries who have set targets to be achieved by 2030 are unlikely to achieve them because of this changing donor, financing landscape that we find ourselves in. Additionally, there is 64 countries that are unlikely to meet their neonatal mortality targets, as well as under 5 mortality targets. What this says to you and I, and to all of us on this call, and I'm sure you've joined because you are passionate about the issues surrounding maternal and child health, but I'm sure also, more broadly in terms of targets we have set for health systems in the African continent. It is therefore very important and very urgent for us to accelerate progress towards achieving specifically MNCH targets. And of course, we know that this is going to be very challenging because of the shortage of funding. And not only shortage of funding, we know that the funding has also been accompanied with reductions in human resource capacity. And therefore, it means that it literally is all hands on deck. It cannot be business as usual. And we have to find a way to creatively and innovatively come up with strategies that will enable us to close the gaps that we are currently seeing in programming for MNCH specifically. So what is the specific objective for this particular session, just to make sure that we anchor ourselves on what we expect to get out of this session? Number one, it's critical that we examine the impact of this changing aid landscape, and it changes daily. And it requires that we become adaptable and flexible, but we need to have a way of coming into grips with what the impact is for programming, not only at facility level, but at community level, and especially for the recipients of the programs, that have now, many of which, have been shut down completely. We need to examine that landscape. Number two, amongst ourselves as stakeholders, we need to foster collective action. There's so much progress and so many gains that we have had over the years on MNCH. And we know that, this changing landscape obviously puts, us under pressure. And it also seeks to undermine, the progress that we have made. And therefore, collectively, we need to safeguard the strides that have been made and find a way to progressively move ahead despite the challenges that we currently face. And of course, as one of our core values and strategies is around innovation. And it's important for us to have a discussion, especially as stakeholders in different regions. We've got people in different regions, Asia, we've got people in Latin America, in the African continent, in the US. And therefore, we bring a diversity of experience in terms of some of the innovations that are being implemented, particularly around innovative funding mechanisms. What is happening in the different regions where you are, in the organizations where you are, that is innovatively seeking to address the funding gaps. And we're going to be talking about that this afternoon. And of course, there's also recently shared data on maternal, newborn, and child health, which we're going to dive into because we want to make sure, obviously, that we are anchored on recent data and numbers in terms of the gaps that we are hoping to fill. So those are the objectives, and it will be great, even as we continue to chat and welcome people who are joining, for you to communicate your expectations and, of course, any ideas that you have, continue to put them on that chat. I'm so pleased that we have got such a illustrious panel. I must say, these are people who are at the best at what they do, and they are leading programs in global organizations, and they have been thinking quite keenly about this particular topic that we're going to be addressing today. And some of them are policymakers in ministries of health. Some of them are involved in actually implementing programs, but also in terms of the supportive supply chain and other services that are required to make maternal and child health services work. And I'm so pleased to be introducing them to you so that we can get from them the insights that will drive this conversation forward. We've got 5 speakers, and they are going to be speaking on different aspects of this particular topic, but we are pleased to have the Pan American Health Organization, that is PAHO, represented by Dr. Suzanne. And Dr. Suzanne is the Women's Maternal, Neonatal, Sexual and Reproductive Health Unit Chief. So Dr. Suzanne is the chief at PAHO, and she's going to be talking to us around how PAHO as an organization has really been thinking through this changing aid landscape and how they have been innovatively trying to rethink the future of MNCH. And just for you to know that Dr. Suzanne is a gynecologist and an obstetrician. And prior to her work at PAHO, she worked at the Latin American Center for Perinatology, and including women and reproductive health. And she worked firstly as a regional advisor on sexual and reproductive health. And from 2014, she took over as director. She has published books, articles, in scientific journals and women's health magazines, covering a broad set of issues that cover maternal health and child health. And so it is an absolute pleasure for us to welcome you, Dr. Suzanne, as you take us through this particular topic. And I just have one question to kind of ask you, even as you delve into, this particular topic. We know that PAHO is a leading, global institution that has been working quite innovatively on maternal, women and child health in that part of the world. And we're very particularly interested in how you have worked within the landscape, particularly of public-private partnerships, and how you have leveraged on the almost like non-traditional partners in order to address some of these challenges. So Dr. Suzanne, you can take us away. Thank you.
Thank you for this presentation, and thank you for all before the video, the beautiful video. And I'd like to begin to explain that we are responsible for all this hemisphere. We are the regional office for the Americas of the World Health Organization, and as a specialized health agency, we have in 27 countries offices and advisors, national advisors. And before you came unity in the headquarters in the Washington, we are for more than 50 years a center, a specialized center. And why I say this? Because when the actual director, Dr. Jarbas, assumed the direction of PAHO, he asked us to bring innovation between all partnerships, because he believes that we can go alone in any society, as you know, and we need to be more than donors, partners, the institution, the society, the civil society, the people that is able to be with us in this journey. So this is the difference between in the years before, in the last, I say, 5 years. And we have differently, ways to do this as a multilateral agency, that you have different roles. So let me explain a little bit why we try convince people to become PAHO partner. In this particular issues, we have a strong brand as the best partner for health transformation. We believe that PAHO is responsible in the America to change the landscape of health and the women's health. So we also have challenges. We also have a very different areas in the countries, between the countries, that need more attention. They have bad numbers, they have bad rates of maternal mortality. So we try to treat this differently for every partner and every donor and in every territory. We can see all the Americas as one. You need to see America differently for each part. And how we work. We try to make partnership in all of society. So you have from academic research institution until the private sector, because the private sector for many years was not a usual partner for us. So we try to bring them with us with roles. So PAHO approved a resolution that Mercedes will talk a little bit about this. It's one of our main questions, main issues in our relationship with them, that called FENSA, this Framework Engagement of Non-States Actors. So with this, we are able to make partnership with all kind of different actors. And I would like to invite everyone that is in this presentation, in this moment, to see our page, that you have more than 300 experience with those actors. And how you build each one is different, because as I told, in all the America, we have different situation. And as I stated in the beginning, we need investment, we need political will, but we need good experience to convince that with good evidence, we can really reach our goal. So let me bring in this conversation Mrs. Colomar. She is a consultant in PAHO, and she is the person that take this in the field and have the best takeaways for all of you. Mrs. You have the floor, please, go ahead.
Okay, thank you, Susan. Yes, I'm going to reflect about some, about this experience from receiving donors, collaborations with, from partners. So, I'm sorry, okay.
I'm going with the presentation.
Are you going to?
Yes.
Okay,
yes.
Great. So engaging with donor partners involves meeting a series of institutional requirements. While these may seem bureaucratic at first glance, they are essential mechanisms to ensure transparency, avoid conflict of interest, and uphold ethical and financial accountability. So the first step in this process is to align with PAHO's framework of engagement with non-state actors, FENSA, which Susan mentioned a couple of minutes ago, this framework defines the purpose, guiding principles, and benefits of engaging with external organizations while protecting the integrity of PAHO. FENSA ensures that all the interactions follow established standards and includes specific policies for each type of non-state actor. In this case, it was PAH. So following that, we were required to sign a technical cooperation agreement with FAUNS to complete a risk assessment provided by PAH, which required a review and approval by PAHO financial department. And obviously, we had to undergo the PAHO IRB for the ethical review. So while these procedures are critical and involved different departments and offices from PAHO, the pathway was not clearly systematized, which led us to unforeseen delays and added complexity. So the first and most important lesson learned is not to underestimate administrative timelines and to recognize the need to streamline internal processes in order to be more donor-friendly. So we're in the next PowerPoint. Are we on the next slide? Because I am not seeing it. So all of these administrative process require an investment of nearly 10 months, a time frame that had not been originally anticipated in the project planning. What was initially designed as a 12-month project ultimately had to be executed in just 3 months. This dramatic compression placed significant pressure on implementation and caused delays for the donor, who also operates under strict internal deadlines. So these delays had a direct impact on workload distribution, leading to bottlenecks, congestion, and increased stress on both timelines, PAHOs and PAHs, and resources. In other words, the second key lesson learned is the importance of realistically anticipating administrative timelines and not underestimating them, even when we believe we have accounted for such challenges based on this past experience. Planning must intentionally include administrative time as a critical phase, not as an afterthought, if we are to meet expectations and maintain strong relationships with the donor and with our partners. So to the next slide, please. So our Women Health Unit, former CLAP at HSS, has been coordinating this network of Sentinel centers from 2015. This is a collaborative network of institutions whose main objective is the monitoring of maternal and neonatal health. It is made up of 15 institutions across 9 countries, all of which use the same data collection system that is called SIP for its acronym in Spanish. This is a clinical record that documents information from pregnancy through to newborn outcomes and maternal outcomes. And thanks to this network, numerous research questions, you can see here the number of articles and research, have been explored and answered. This is the evidence of the scientific production we had with the network. But this network is collaborative in nature and operates thanks to the commitment and dedication of its members. Though the lack of funding for this network, along with limited human resources in Latin America and our region, poses a challenge to data quality. While SIP captures a large amount and detailed information on maternal history, pregnancy, and outcomes, and while there is a quality monitoring in place for many key variables, the retrospective nature of data analysis to answer certain questions means that specific variables which are not being actually monitored during data entry may require adjustments. This highlights the importance of continuous support to ensure data completeness and accuracy. The next one, please. So we collaborated with PATH to answer a key research question that was evaluating the timing of antenatal care visits to gestational age, recommendation for maternal immunization. But as an example of data quality restrictions, we had to exclude Bolivia from some analysis since its national health records by policy decision only included information up to 7 antenatal care visits. And we also had to exclude data from Argentina due to issues related to data quality. So in this figure, you can see the number of institutions by country we finally got to include, which led us to our third takeaway, that is, as mentioned, that the high quality data needs sustained support. To the next one, please. So synergy between institutions with different backgrounds but shared goals, like PATH and PAHO, is key to strengthening our ability to address questions and advance knowledge. This is our fourth key takeaway. Because the founding of strategies like this network, which is unique in the region for offering comparable information across several countries, plays a critical role in strengthening existing capacities and improving the quality of health data systems. This support not only reinforces the infrastructure already in place, but also leads to significant improvements in the quality of clinical records. It enhances the reliability of the data collected and directly contributes to the institutionalization of SIP as a standard data collection and health monitoring locally tool. To the next one.
Thank you. Just a note, Mercedes, that we must just try and move it along a little bit. We're running a bit behind. I'm sorry to put a bit of pressure.
Okay, this is the last one, my last
Okay.
reflection. That last but not least, the team's ability to combine technical expertise with empathy, resilience, and collaboration allow us navigate the complex challenges that arose. PATH and PAHO not only ensure the technical soundness of the work, but also foster trust. Both teams' commitment and problem-solving mindset were the difference between a project that merely met its target and one that truly drives sustainable impact and hopefully transform this short-term collaboration into lasting partnerships capable of generating lasting change. And that's it. Thank you very much. Thank you for your attention.
Thank you. Thank you so much. I was just taking so many notes as you were talking and really, really appreciate the insights that you have shared. And I love how practical they are, and starting from the importance of having a framework. And I think my takeaway there is that partnerships are not a haphazard process of partnering with whoever is available on an agenda that is not clear, you know? I think I take that away. Sometimes I think whenever there's an opportunity to partner, people often just, you know, haphazardly, without thinking about a framework for engagement. And I think that is key. And even with that framework of engagement, we can see some of the practical challenges that you encountered in terms of, administrative processes, in terms of an environment that might not be fully conducive to kind of support the partnership. And so it's also important as we think about partnerships, particularly for maternal and child health, we think within the context of an ecosystem. And you brought that forth as well when you were talking about the collaborative network that existed. So partnerships are not like a solo act, okay? You don't go into a corner as an organization and decide you're just going to form your own, partnerships on the side, but you have to have a clear understanding of the ecosystem in which you are working, backed up by robust data, that gives you a sense of the real situation on the ground, and that will drive, your partnership. Please do keep your questions coming on the chat. We will open some time to get into a conversation and try and get our panelists to answer your questions, but we'll come to that a little bit later. So in the meantime, just note your questions for us. But thank you so much, Mercedes. Thank you, Dr. Suzanne, for such a very insightful, conversation. I have 10 questions myself, even though I'm the host, but, I won't ask them. I'll leave it up to the participants to engage with that conversation and sort of take any sort of questions that you might want to pose towards the end. At this point, I do want to introduce our second panelist, and his name, is John Paul Omolo, and also known as JP. And JP really sounds like, you're going to be a DJ, JP. So I hope that you're really going to give us a very entertaining talk on these issues of partnerships. And of course, JP is a distinguished health policy expert, and he works with Roche within the Division for Policy and Government Affairs within the Africa region. JP has got over a decade of multifaceted experience in health system strengthening, in policy advocacy, as well as government relations. He leads the strategic advocacy efforts for Roche that shape diagnostic policy priorities across Roche's key African markets. So JP is the right person for this conversation because he has experience in diverse African markets within Roche. And previously, before joining Roche, he led R&D policy and advocacy within PATH. I'm tempted because you're kind of coming from PATH to sort of put in a couple of plugs, but I won't do it, JP. I will resist. And just continue to say that JP's focus has been on pharmaceutical manufacturing, on regulation, pandemic preparedness, and health research. It is an absolute pleasure for us to have you, JP, as a panelist with the experience that you have. And I think one key question for you is how can African countries leverage partnerships with pharmaceutical companies like Roche? We know that, the high costs of procuring drugs, and medicines, particularly for MNCH programs, can be very prohibitive. And it's quite important, within the current changing donor landscape, as we have said, for us to find ways to partner meaningfully with pharmaceutical companies like yourselves. How can we do this, JP?
Thank you so much, Ntemba, for that great introduction. And thanks to the PATH team for organizing this timely conversation for us in Africa and for us to help address. And I want to take this moment and ask all of us to reflect, ladies and gentlemen, about the situation that we are in. And in this case, let's think about this mother in the western part of Kenya. And I'll call this mother Amina. Amina just delivered 2 months ago her beautiful baby daughter called Zora. And today, Amina seems to be having a bit of a challenge. The baby is running very high fevers, and Amina, since her delivery, has not had a moment of peace because she's been having a lot of pain, excruciating pain, as well as a lot of headache. On this day, she decides to walk to the clinic, which is about 5 kilometers away. All the way to this place, she's only armed with a bottle of water and a bottle of milk for the baby. After the 5 kilometers, she arrives and finds a very long queue. She joins the queue, and after an hour and a half, she's able to be ushered in to see the clinician. She presents her symptoms. She talks about her symptoms and that of her baby. And post that, the clinician asks Amina to go and get her lab tests done, including her baby's. Getting to the laboratory, the lab tech informs her that they are running out of some of the solutions and tools, especially the reagents, and therefore Amina has to walk out to the nearest facility, which is about 1 kilometer away, to get her lab tests done so that she can come back with the lab results and see the doctor. This is a government facility. Therefore, Amina tries to leverage the free, or what I would call the low cost of care. She walks again the 1 kilometer, to go and get her lab tests done. And upon reaching there, she gets her blood and that of Zora taken and waits for another 45 minutes for her lab results. After 45 minutes, she's given her lab results, but not that of her baby, Zora. And she's told that her baby's results, Zora's results, will be out after 24 hours, which means the following day. But additionally, she's asked for 150 Kenya shillings to pay for the lab results. This is the money she had all along, but was meant to be used for food later that evening. She walks back to the first facility, the government facility, with her own results and sees the doctor or the clinician. But upon reaching again, she doesn't have Zora's results. That's her baby, who is just 2 months old. But because the doctor cannot just leave the baby go, they gaze out that maybe because of the symptoms Zora is having, they think it could be malaria or a bacterial infection. And therefore, they prescribe an antibiotic for Zora, and they let Amina go. It is now evening. Amina walks home, uncertain, anxious, and alone in the dark. Ladies and gentlemen, this is not fiction. And this is the reality of thousands of mothers across Africa. The poor access to quality diagnostics, delayed treatments, and fragile supply chains continue to undermine the maternal and child health outcomes. We lose approximately 178,000 mothers and over 1 million newborns every year in Africa. And a lot of the deaths, especially from mothers, are from, preventable conditions, such as hemorrhage, hypertensive disorders, infections, unsafe abortions, obstruction labor, and name them. All these conditions are largely preventable. We recognize how far we've come, especially in Sub-Saharan Africa. In the year 2000, maternal mortality was at about 727,000 per 100,000 live births. At the moment, we are at about 442 deaths per 1,000 live births. Against a target of 70 maternal deaths by 2030, we are in 2025. We are hardly 5 years to our target. While innovations in the medicines, in diagnostics, and data exist, Financing for scaling them do not. And unfortunately, for decades, Africa has over-dependent and over-relied on donor funding, which has proven now to be extremely unsustainable and extremely shaky. Ladies and gentlemen, we have a responsibility, all of us in this place, to rethink the financing delivery, and especially for diagnostics and preventable services, which for a very long time have not been thought through. These often receive the least investment but have the highest impact. So where does our answer then lie? Two things that I'll mention. One, innovative financing and strategic partnerships. And I know that's where we are. So what do those things two mean? For us to have those innovative financing, the first thing we need to do is to have a very strong blended public, private, and philanthropic capital. If you look at several policies across the continent, ministries of health, the word public-private partnership exists in almost every policy, especially when we are developing those kind of policies. But unfortunately, we never take an inch after putting that to explore what does PPP mean and what models works for us and works within that context. We must start exploring the different public-private partnerships, and I'll speak to a few examples borrowing from Roche. Secondly, we must also de-risk the private investment, especially in MNCH products, through guarantees and co-financing. And lastly, for us, we must also embed sustainability and local ownership. And I want to borrow from two critical examples that Roche has been able to do. One is our recently announced Global Access Program, which is a program that has prioritized access to diagnostics and capacity initiatives to tackle infectious diseases, especially for HIV. And with this, Roche has collaborated with governments and local organizations where we've extended the pricing subsidies. This program ensures that governments are equipped to provide HIV diagnostics tests at the lower negotiated cost that the global funds and PEPFARs were buying them at. This is a program that can be scaled and can be reached because countries are already accessing these products at these prices, and therefore it is something that is affordable to countries. The second is in our oncology projects and our oncology work. And in this, we've tried to incorporate innovative financing mechanisms and partnerships to transform the healthcare outcomes. We know and recognize that cancer is such an expensive affair and very hard and very difficult to treat. By introducing affordable, high-quality HPV DNA testing and collaborating with governments and other stakeholders, Roche has improved early detection rate, accessibility for underserved communities, and ensuring that such kind of initiatives are also subsidized, especially for the diagnostics and medicines. Most recently, Kenya, the Ministry of Health, signed an MOU with Perth so that the Kenyans are able to access high-quality medicines, cancer medicines, and diagnostics that are being reimbursed within the Social Health Authority or Social Health Insurance Fund. So it is within that cap of reimbursement. And those are the kind of partnerships and public-private partnerships that we are looking out for. And we are hoping that can be scaled. And Roche has also ensured that with this kind of initiatives, we are able to increase access, we are able to double screening, we are able to ensure there's early diagnosis, and we are able to save lives and livelihoods, demonstrating that this is scalable and sustainable solutions. As I conclude, I would like to say that if the world and if Africa can be able to finance moonshots and mega projects, surely we should be able to fund mothers and babies' health. And therefore, for us to really transform maternal, newborn, and child health outcomes, we need to adapt partnerships and models that shift from charity to co-investments. We need to tell stories that humanize data, and we must also ensure that we meet the needs of smart blended financing. And finally, through examples like the case scenarios like the Roche ones, we need to show that impact and sustainability can coexist. Thank you, and back to you, Temba.
Thank you. Thank you so much, JP. Really, I'm just enjoying, these talks, especially because of, how practical, and I like the examples that you have made in terms of how Roche specifically is putting in place these frameworks that, Dr. Suzanne was talking about. Because it's one thing to have a framework in terms of how you are going to approach public-private partnerships, but we are seeing from Roche how you've actually implemented that framework and how it is bearing fruit indeed from some of the examples that you have said. I can definitely see such a lot of engagement in terms of questions and just comments from participants, and really just once again to appreciate, the over 100 participants that we have, and encouraging you to continue to engage. And I just, as we're going to move to the next talk from Ms. Emily Chira, who comes from Malawi, but before we move on to that, I just wanted to quiz you, JP, on whether, there's any specific way in which different organizations can tap into some of the support that, or the frameworks that you might have in place as Roche. I know that you have got your own sort of partnerships as you have put the examples, but how do you engage with the broader sort of ecosystem of the partners who are represented in this call? I can see people are quite inspired by some of the examples that you have shared. And I guess there is a sense in terms of beyond just those two examples that you have shared, what other ways exist in which people can also engage with you? Just quickly in like 1 minute. Thank you.
No, thank you so much, Temba, and I'm really inspired by so much reactions that are coming in. Roche believes in partnerships, and it's part of our DNA. And therefore, it would be great to follow through with individuals or institutions that would want us to work on things. We partner a lot. Last week alone, we partnered with Africa Society for Laboratory Medicine to build, partnerships, leadership programs for lab leaders. And therefore, there are also so many others, and I'm more than happy to share the current running partnerships, and also if there could be others that colleagues have and things that are there. I'll be sharing my email address on the chat, so more than happy to engage beyond here. Thank you.
Thank you. Thank you very much. Thank you so much. And just a word for our participants that, I'm trusting that everybody registered and we have everyone's details, because that's important as PATH and our Center for Advocacy and Policy. There's so many resources that are available. You don't need to reinvent the wheel. There's also lots of follow-on sort of opportunities, as JP was pointing out. So we really do want this to be practically helpful to you, and do make sure that we have got your details, and any other additional resources can be shared with you even after the session. Now, I'm excited to introduce Ms. Emily Chira, who is part of the Ministry of Health in Malawi, and representing, of course, government, and working in a context where there has been quite a lot of innovation, particularly as it relates to financing and budgeting. And we are really so keen to hear examples and experiences from Malawi, coming from the Malawi Ministry of Health, and just how you have been approaching this particular changing donor landscape and some of the innovative ways in which you are responding. Thank you. You can go ahead, Miss Emily.
Thank you so much, Note. Thanks everyone, and thank you once again, the organizers of these important conversations for considering Malawi to hear from our experiences. So like you said, I think for us in Malawi, we noted, and I know in Africa, I know we have noted, we knew that something was coming up. We knew that there would be a point that we needed to come in and be in charge of our health financing in Africa. Maybe some of us thought maybe by 2030, 2027, but neither did we know that it was as early as 2025. So in Malawi, just to give a bit of a background, our per capita spending for health is at $40. Is at $40 per capita, and this is against the $6 per capita as advised and recommended by the World Health Organization. So that's what we noted. So we established our health financing division in 2021. That's when we had now the health financing division in charge implementing the health financing mandate. We came up with our very first health financing strategy in 2023, immediately after the establishment. And we also want to thank our partners that during the time that we were just finalizing our health financing strategy, there was an opportunity to hold the health financing dialogue. Malawi was privileged to be the very first country to hold the very first health financing dialogue in Africa. So within that time, that's when actually now the drive to work with the private sector came in. So we had a meeting with the private sector. We had meeting with our banks. We met the whole private sector, those already implementing healthcare, but also those supporting healthcare through corporate social responsibility, but also the financing, the financial institutions, the banks, the discount houses. We met them. We shared them now the data on health financing. Because I think some of them had no idea what was happening in the health sector, but also the fact that our financing was largely externally financed at 56%. So after that meeting, we agreed that going forward, we need to have a forum whereby we continue meeting. So we have actually now developed the Health Financing Forum, where now the ministry meets the private sector. So this is under the Health Financing Technical Working Group. So we've got a sub-TWG that now just looks at the private sector because we thought they are a special area that as a minister we need to focus on. Also realizing that our major drive for our health financing strategy dwells much on domestic financing. So within the domestic financing space, we are saying it's high time that Malawians should start contributing towards healthcare because healthcare in Malawi is for free, but also what can the private sector do? So when we talk to the private sector, we are looking at two fronts. We know that the private sector, they need to survive. So they need to make profits. So they are not there to provide charity work. No, they also need to make money so that they thrive. So we are looking at areas whereby the private sector can invest, make money, but at the same time, as a country, we also benefit. So for instance, we've got specialized areas of care that currently Malawi sends people to India outside for referrals. We spend a lot, but if somebody comes in and invests in that area within Malawi, we'll be able to spend more people. It will bring in efficiency. So we are looking at such areas whereby they can come in, put in their money, we give them business. But also we are saying the private sector already contribute towards corporate social responsibility. So we are also saying, how best can we work together? So under this one, under the corporate social responsibility, what we are doing now is that we are finalizing our capital investment plan. And within that, then we will identify areas whereby now the private sector can come in and support. We are also trying to work with our colleagues from the Ministry of Justice, but also Parliament, to see if maybe we can also make some of this mandatory so that if a private sector in Malawi, you are producing beer, you are producing some of those undesirables, then maybe your CSR should be mandated to go towards healthcare. So we are also trying to explore how best some of those can be implemented so that the private sector can also participate. And through this forum, we are also trying to make sure that the private sector are part of the one planning agenda in Malawi. So at the beginning of the year, our planning is that we have a meeting with them. We understand how much they have planned for CSRs, and then we see which areas they can support us with. Immediately after finalizing our CIP, which is due in a month or two. Yeah, so just to say that under the areas whereby now the private sector want them to come in and invest where they can make money, we have a consultant on the ground. So we also want to have information for the private sector. So it's one thing to say you can come in and construct a cardiac facility. We'll provide you business, but we need to do some kind of financial modeling and all that. You see if that project is indeed feasible for Malawi. So we have a consultant on the ground working on a compendium of all investment projects that private sector can invest in and make money. So he's on the ground. Our plans are that come by December, this document should be ready. I want to report and share that actually the private sector are waiting. We have people calling us, when are you finishing with this work? Because they really want to come in and start investing so that they are also making their money at the same time. And from our side, we want to make sure that to make this doable, we are exploring blended financing for such projects. Other than that, we also work with the private sector under those under Christian health facilities. So we've got over 6 million Malawians accessing care under CHAM. We have service level agreements whereby the ministry we send our people to their facilities. They have a small fee that people pay because they are not for profit, and we reimburse them. So under the service level agreements, I can report that we've got over 70% of our clients there are mothers and children. So these are the very first people. So we've got a health benefit package. We've got a package that can be accessible, and depending on the money that we have, we can have a full package. If not, then at the bare minimum, we will provide under 5 clinics and under 5, but also maternal health issues. We have also in our health financing strategy, we have also identified our central hospitals. We are trying to make them financially independent. So under that, we've got a project to construct independent hospitals within our central hospitals, which should be cash cows for our central hospitals. And we are sure that if we construct such facilities within our central hospitals, they will graduate from getting ORT from the Ministry of Finance. And that money that currently they are receiving, that is the money that we also want to redirect towards primary health care, our health centers, maternal issues, especially for people living in the remote areas. And also just to say, currently we are working with AXIMED. AXIMED is one of the private sector in Geneva. So they are also involved in food procurement. We should be signing an MOU soon. We have realized that working with such private sector also helps us to benefit in terms of efficiency. We'll be able to get quality medicines and commodities, but also at a cheaper price. I think some of you, maybe you have seen a report which says 70% of medicines in Malawi are counterfeit. So it's so worrisome. And as a ministry, we are also trying to see to find ways whereby we can be assured of what we are buying. So one of them is to work with such companies of high caliber, and we are sure that whatever they are procuring for us is really indeed what we are looking for, and it's genuine. So just to mention that there is one initiative that we are working with AXIMED. We also work with private hospitals within Malawi to offer some of our services, especially under 5. So like we provide them with vaccines, and people from all over can also access such preventive measures within the private hospitals. Yeah, so in a nutshell, that's what we are working on in Malawi. It's I've come to learn that it's one day at a time. Slowly, we are making progress. Slowly, we are also seeing the enthusiasm from the private sector to work with us. And when the announcement by the UK government was made, they were really exciting. And one thing that I want to mention before I finish is that we are also trying now to find a proper home for this private sector, for the secretariat. I mentioned that we have a technical working group within the ministry, but then we have realized that, yes, we may have that, but we need a proper home. We have learned that our colleagues from the West Africa, they have got what they call the Private Sector Federation. So we are having discussions with our chambers of commerce in Malawi, which commands a lot of the private sector in Malawi, to set up a secretariat within there, so that when we need something, it's easier for us to coordinate and also to call them than us calling one by one. So in a nutshell, that's what we are doing in Malawi. Thank you, and over.
That is wonderful. That is really, really great. Thank you so much, Ms. Chira. And I must say, I think, the Malawi experience is quite progressive, all the way from setting up dedicated structures and teams, ensuring that you engage with the private sector in a very structured way, but also, practically, I like the example that, you made around maternal and health and child health services being accessible in private healthcare facilities, and government being able to reimburse those private providers for that care. Really quite progressive. If you do take a look at the chat, you will see there's quite a lot of response. And because of our time, I will ask that you look at the responses to your questions. If you go to that question and answer section of our chat, some of your questions have already been responded to. In the event that we don't have time at the end to kind of go through all of the questions and provide answers, so we'll ask that you pose the questions on the chat and you look at the responses there. Thank you so very much, Ms. Chira. Really quite an insightful and progressive experience from Malawi. I do want us to move our program along. And of course, we always apologize to the speakers that are towards the end of the program, but we do want to respect the time for our participants. And we're asking that we just focus on the core parts, particularly those that have not been mentioned by other speakers. But right now, I would like to introduce Dr. Gadari Ndirangu, who is a seasoned obstetrician and gynecologist, and he's got decades of experience across clinical care, research, and public health. He's currently the Chief of Party for the Momentum Country and Global Leadership Program under JPEGO in Kenya, and he leads a dedicated team. And the very special thing is that that team, together with Dr. Gadari, work very closely with the Ministry of Health in Kenya to strengthen maternal, newborn, and child health, as well as nutrition for supporting high-impact, life-saving interventions. Dr. Gadari, we're looking forward to your talk and just your own experiences within not only JPEGO, but the Kenya context as well, in terms of how you have approached partnerships and leveraged on them. Thank you very much.
Thank you, Notemba. And of course, coming in from the rich conversation that we've already had from the previous speakers actually makes it easy. And like, for example, John Paul humanizing data, for example, will say every 2 minutes a woman dies from preventable, complication during pregnancy or childbirth, or every 2 minutes, or every minute a child under 5 succumbs to avoidable disease. But I think Amina and Zora, as narrated by John Paul, really humanize that and give us an element. And this really also gives us an opportunity to appreciate and recognize the fact that private healthcare on this continent is huge, is a big business. It's really, we do know that as heterogeneous and as fragmented as it is, 50% of all care comes through, including maternal, newborn, and child health, comes from this sector. So I think it's something that we should not ignore, even though for many years, I think we largely let it to run on its own. And I think governments perhaps here also take a little of the blame for that. Of course, they have their own issues and of course the successes, but also problems. And Emily, of course, articulated that very well. But I think it is time that we really need to recognize in countries that really we cannot ignore or continue ignoring the private sector. And we must insist that those who can afford to pay for services, they do so, but also get quality services. And I think, of course, is that having mentioned that, is that I think even as we think about the private sector, is looking at quality, making sure that then there are strong regulatory frameworks across each of the countries that we have, quality assurance mechanisms, and make whatever that they are doing in the private sector is aligned with national health strategy. And that also means that capacity strengthening, especially in service, and national reporting systems and standardization must traverse these sectors. And I think, as you do mention, is and I think speaking a little bit about the Coalition for Women's Health in Africa, is the need or the value to elevate the role of public-private coordination platforms, where the coalition really has come in and stood out as one of the continent-wide initiatives or platform to help collaborate between the private and public sectors for women and children's health. And I think we do really recognize and appreciate that. And of course, JPIGO, where I work, having also being a member of their coalition, again, has for many years, of course, JPIGO is more than 50 years old now, has also great examples where we've seen really genuine and meaningful partnerships with private sector players, giving tangible results that improve and change and transform the lives of people, women and children. And I think in one of these, and Yaduni mentioned last time, during last month's part one of this webinar, the tripartite agreement between WHO, MAC, MSD for mothers, and Ferring. One thing is that JPIGO has been implementing through this mechanism, what we call accelerating measurable progress and leveraging investments for PPH impact, or amply PPHI, that really has taken advantage of that ability to have heat stable carbetocin, and of course additional interventions to prevent and treat PPH, to be able to drive access to this life-saving commodity. And of course, heat stable carbetocin really not as a replacement for oxytocin to prevent and PPH, but rather to address the challenge of cold chain that is commonplace in many of our settings on this continent. And I think the thing is, we know that having been implementing this in multiple countries, of course, through funding by various entities, UNITAID and the European Union, is that we've seen now countries like Kenya, for example, is now procuring heat stable carbetocin through the National Medicine Supplies Agency, known as the Kenya Medical Supplies Agency. And we've also seen that really yielding that, in fact, indeed, this, of course, plus additional, the whole bundle of interventions to prevent PPH or postpartum hemorrhage or bleeding after birth. And in many of the geographic or subnational entities in the country, we are seeing many months going with zero maternal deaths from bleeding after birth. I think, of course, this, in addition to this, there has been significant advocacy to promote local manufacture of calibrated drips that are important for measuring and estimating blood loss, but also significantly in reducing the cost of that. I think for the other example really is a mechanism we've been having that is funded by Gates and Bayer, the Challenge Initiative in East Africa. I think catalyzing, cities, municipalities in the 3 countries of East Africa, Kenya, Tanzania, and Uganda, to implement family planning, HIPS has been able to and mobilize on resources, has really resulted in a 30 to 50 increase in uptake of family planning, and especially among younger individuals, adolescents and youth who traditionally are disadvantaged in accessing care. In terms of JPIGO having worked closely with private health providers, I think we have great results of making sure that our training is integrating both private and public, being able to standardize protocols irrespective of where one is working, but also that has resulted in increased attendance of skilled birth attenders in many facilities by up to 25% in Kenya, Nigeria, and Tanzania. I think also the fact that we do recognize the value of pharmacies. I think the new frontier that we are finding quite exciting and also, riding on the tailwinds of COVID is e-pharmacy or online pharmacies, where we've had successes in HIV exposure prophylaxis, but now we venture into family planning and digital counseling with direct to consumer delivery right at the doorstep of the user, and that has also obviously enhanced self-care. But in addition to that, it has given us an opportunity to support governments to think about strengthening or enhancing the digital health environment in the countries, and of course, improving competencies among providers across the board, so that then, wherever they are, they're able to access services. I think, in fact, if the story of Amina and Zora, if it was a setting where they're able to have services closer to themselves, perhaps the long waiting, the distances would definitely have been taken care of. So again, really thinking a lot around making sure that whatever we are doing is centered around the user. And maybe just because I know pressure of time, I really want to make this short, is I think some of the things that we've seen is that lead to success is making sure that whatever we are doing, we are co-designing with local systems and aligning with national priorities. I think Mercedes talked a lot about making sure that everything is centered on humans. But you also see the value for innovating for context, not just innovation itself, but innovation that responds to the particular ecosystem that you are dealing with, whether it's digital or whatever kind of innovation that you're seeing. The other element is thinking around blended funding. So there's no single way, like, catalyze and then ask domestic resources to be mobilized. That actually does mobilize resources from the ecosystem or the specific context that you're working in. And of course, not forgetting quality and accountability from both ends, the user and their users' responsibilities, but also the providers, the service provision for both the public and private sectors, making sure that they are responsive to that. And again, really talking about building trust with the community through community engagement that is meaningful and listening, like we are really genuinely listening and doing what is responsive to the needs of the people. And I think, like we mentioned earlier on through the Coalition for Women's Health in Africa, is coordination, making sure that there is healthy coordination. You're also promoting healthy competition, sharing lessons even within the private sector. And I think Emily also touched on pool procurement, which can obviously improve the cost and profit margins for private players. But as advocates, because I do believe that part of this is really to continue pushing and advocating, I think it's important for us to continue reminding everybody that investing in MNC is not just a moral imperative for us, but it's actually economically smart. And for this continent, just the fact that the World Economic Forum does estimate that $1 invested in MNCH yields about $20 in economic returns. I mean, 1 to 20 ratios are huge. And this is productivity, reduced healthcare costs, and many, many other things that are very helpful. So I think even as you are engaging whoever it is, the people who want to think about money, our economists, our treasuries, our philanthropists, I think the wider corporate sector, thinking a lot as this is as an investment, not really just responsibility, but as corporate social investment, in that, if the community is healthy, the more money circulating, there's higher purchasing power, the customer base improves, and also the workforce. And of course, many other benefits as you're thinking about, so that it's not just seen as that poor woman somewhere, but it's really something that is helpful to the wider community, especially economically and in terms of development. And finally, I just want to add that the future of Africa, MNCH in Africa, really depends on strategic, equitable, and scalable partnerships. I think we've already had that. But the private sector in its own brings innovation and efficiency and reach that we should not ignore. But of course, it must be aligned with public goals and community needs. And so as I finish, really, let's continue to rethink and reimagine what's possible. Of course, together, especially with the dwindling foreign aid that you are going through. I do believe that this continent has resources that are sufficient to make sure that the health of women and children are the best possible. Thank you. Over.
Thank you. Thank you so much, Dr. Kadari, for such a stirring and really, once again, very practical talk filled with examples. And thank you so much to the participants for continuing this conversation with us. We know that we're running a little bit behind on time, but we have only our last speaker, who's really such a great segue into the talk that Dr. Kadari just gave us, because it's about supply chains. And this is Mr. Mark Osiemo, who is with InSupply Health. And we spoke a lot, or at least we've been mentioning, around the ecosystem and the importance of having the required supply chains supporting innovations, particularly in availability of medicines for maternal and child health in particular. And just asking everyone to hang tight. I know that we've only got a couple of minutes left, but this is our last speaker. And after that, we are going to be wrapping up. Just to remind you that the questions have been responded to on the chat, and encouraging our speakers and panelists to also go to the chat, because there's a lot of engagement and some questions and comments that might be worth attending to, because we definitely will not have the time at the end to go through the questions. But in brief, Mr. Mark Osiemo basically works for InSupply Health, where he leads a project aimed at strengthening national and sub-national level capacities in terms of forecasting, financing, and procuring MNCH medicines and other supplies. And I'll just, in the interest of time, Mark, just give you just this couple of minutes for you to just give us, the highlights in terms of supply chain management and how it can support the MNCH interventions that we are all driving towards. Thank you.
Thank you, Notemba, and my fellow panelists. So in the interest of time, I will keep my discussion brief based on the supply chain interventions that we've witnessed in Kenya specifically. So maybe just to bring it home, in Kenya, generally, we have witnessed substantial improvement in maternal and child health outcomes. But there's still some work to do in terms of access to MNCH products, and this has not been fully achieved, which is attributed to issues to do with stockouts, high cost of health products, and regulatory provisions, and also supply chain related issues. At InSupply Health, being a health advisory firm, we have been working very closely with the Directorate of Family Health and also the division of RAMCA, just to quantify priority MNCH products such as the NASG and also the heat stable capetocin that has also been mentioned earlier, just with an aim to understand the total requirements for MNCH products nationally as a way of ensuring provision and also availability of quality maternal and newborn child health products. This division has been able to facilitate a collaborative approach with other supply chain partners, including partners who had projects that were previously funded by USAID. As per the question that you've posed today, understanding this gap and just being able to maximize and optimize our resources for funding commodities is even more critical at this moment. And equally important is to invest in greater and collaborations and partnerships to identify new and existing proven innovations. And Notemba, you've already mentioned that there's no need to reinvent the wheel. So if there are interventions or other innovations that are working in other countries, we just need to adopt those ones based on the changing aid landscape. At InSupply Health, we have also supported the National Ministry of Health in undertaking quantification of at least 21 priority MNCH commodities, and this has been in collaboration with other partners, including PAP, who are the host for this particular webinar today. 2 years ago, we did what we call a landscape assessment in 4 counties in Kenya in collaboration with Thinkwell and Chartered Institute of Procurement and Supplies, just to gather some insights on the bottlenecks that are affecting the availability of these life-saving health commodities, including MNCH products at the health facility level. This assessment actually identified inefficiencies in forecasting, financing, and also procurement. And the 3 partners right now are now implementing interventions in those interconnected areas just to address those bottlenecks towards ensuring the availability of MNCH and other essential health commodities. In addition to this, the forecasting bit, we went further and developed what we now call the strategic resource management tool. And what this tool does at the subnational level is to address inefficiencies in prioritization, especially in looking at the funding gaps that we are having at the county level. So in collaboration with the same key stakeholders, we developed this tool so that based on the quarterly disbursements, because due to the devolved system of government in Kenya, counties are also actually required to do procurement. So they use this tool to do prioritization based on evidence-based algorithms such as the vital, essential, and non-essential, also looking at what we call ABC classification, and MNCH products have actually been classified as vital and essential. Therefore, this means that whenever they are doing ordering and procurement using this tool, these products will be prioritized for procurement, and they can be available in our health facilities. But allow me to move quickly to what we are looking ahead in terms of the goals and also the ideas that we have for innovation and scale that will also ensure we foster resilience in MNCH service delivery. And a quick example is what I've just highlighted. Just scaling these tools, because we have piloted in 5 counties. Kenya has a total of 47 counties. Scaling these tools to the rest of the counties through the Directorate of Health Products and Technology and its key partners will be one of the key interventions that will also increase availability of these products across the country. Let us look at public-private partnerships also in terms of innovative financing. In Kenya, for instance, the government has signed what we call intergovernmental participatory agreements with county governments just to digitize all public health facilities. And this will also include acquiring the required hardware and also implementing pharmaceutical and logistics information systems through what we call the public-private partner engagement. So that will mitigate actually the issue of visibility and also looking at the products, especially the ones that are not reported every month through the national DHIS2 system in Kenya. The last bit that I wanted to talk about, due to the interest of time, is the issue to do with the health insurance scheme. So if we could look at exploring ways that we can expand the social health insurance schemes and also reimbursement policies to allow mothers to access quality MNCH products from private pharmacies and also clinics where government supply is limited. And also looking at how we can separate reimbursement of services from products where there is a greater incentive for all health facilities to stock products more consistently, since they will be paid directly for the products. So currently, as it is right now, both services and products are bundled. So even if a mother receives a service, for example, there is no incentive for them to ensure that they also have, for the facilities to ensure that they also have products, because they will be paid either way for the services that they have provided. So these funds can also be added to what we call the facility improvement funds and other streams of revenue, and they can use these funds to procure more essential health products and also including their MNCH commodities. This is just to mention some of the interventions which may work for some countries to unlock these sustainable resources and also innovative financing for resilient MNCH service delivery. And because of time, I will leave it up there and I'll be open for any questions after this. Thank you so much.
Thank you. Thank you so much, Mark. And indeed, thank you so much to all of our panelists and also to you, our participants who have hung on for the entire duration of this talk. Thank you so much. And we know that, time is always a barrier in terms of allowing us to have just a much more in-depth conversation, but we are grateful for the comments that you have put on the chat, for some of the questions, which I know that some of the panelists have already answered. And we also know, as we have said, that if you keep in touch with us, there are so many other resources that as PATH we have, but also the organizations that our panelists represent. And it is important for us to keep that conversation going. As we said at the very beginning, this was part 2 of a conversation that was looking at the changing aid landscape and how we refocus our attention and priorities for maternal and child health. And indeed, I think I can say our panelists, thank you. You have done service in terms of sharing with us the real life examples of how you are approaching ensuring that maternal and child health stays a priority in the current context. And just in terms of closing remarks, although we would have loved to have a little bit more time, but I must mention that as PATH, we have got the Center for Advocacy and Policy that has hosted this session. Please do get in touch with us. For those of you who might be just joining because you saw the invitation on any other platform and maybe you are not necessarily part of that group of experts, get in touch with us. We do want to continue to communicate and to share resources about the work that the Center for Advocacy and Policy is doing. And of course, this work is linked to the regional MNCH advocacy strategy. This is what we are pushing. There is a regional MNCH advocacy strategy for the Africa region. You have to be a part of this if you are in the maternal and child health space so that you can be kept abreast of the key conversations that are happening in the continent and you can also contribute towards those. I think in the interest of time, I do want to stop there and to thank the organizers and to thank the CAP team, to thank our speakers and our panelists, and of course, everyone who joined with us. Do continue, as I've said, on the platforms that are available to engage with us so that we can share more resources going forward. Thank you, thank you, thank you.
Thank you so much, Ntema.
Thank you.
And the team.